Hello, my name is Aguerrevere. I am currently the director of the Perfusion School at Dominican Republic. Today, we are going to present an advance of the research projects of the students of the Perfusion Master Program in Dominican Republic. We're going to start with Brenda Barreras from Tijuana, Mexico. She is studying about management of obese patients in extracorporeal circulation, a systematic review. In her abstract, she has as introduction, with an increasing population with obesity worldwide, the appearance of cardiovascular disease has also increased together with other chronic diseases. As a consequence, more obese patients require cardiac surgery with cardiopulmonary bypass. The body surface area of these patients generally requires higher flows to cover the metabolic demands in cardiopulmonary bypass. Her research question is, are obese patients undergoing cardiopulmonary bypass managed in the same way as non-obese patients? As methods, she is doing a systematic review of articles published in PubMed, Google Scholar, Cochrane, Prospero, and Medline database. Without a time limit, since limited data published in this field related to obese patients going into cardiopulmonary bypass. She is using the PRISMA criteria to identify the following articles. The search was carried out using the terms obesity and CPB and or cardiac surgery and body mass index and CPB. After reviewing through PRISMA, a total of 11 articles were included, 1 review, 1 retrospective, and 2 randomized control studies, 3 perspectives, and 4 case reports. She classified the studies by the outcomes. 1, heparinization and reversal of anticoagulation. 2, modification of CPB circuits and flows. 3, report of cases of special management of obese patients in CPB. In her results, so far, she has found regarding the modification of the circuits, it is feasible to use smaller circuits and reservoirs in obese patients, obtaining higher levels of hemoglobin. Parallel oxygenators are not significantly useful in this type of populations. Perfusion flows with cardiac index lower than 2.4 have been used, and the organ perfusion parameters, such as venous saturation and urine output, are comparable in relation to conventional management. 3, the results of studies agree that using lower dose of heparin and body mass index guarantees adequate anticoagulation in obese patients.
Hola, soy Yajaira Ramírez de República Dominicana. Mi tema es caracterización de heparinización sistémica en cirugía cardíaca pediátrica congénita bajo circulación extracorpórea en el periodo mayo 2022 a mayo 2023 en CEDIMAT, República Dominicana.
So Yajaira is studying characterization of systemic heparinization in congenital pediatric cardiac surgery under CPB in Dominican Republic at CEDIMAT. So for her introduction, she says, the use of heparin favors the mitigation of the procoagulant conditions typical found in CPB. The physiological characteristics of neonatal and pediatric population with congenital heart disease, it's different from those of the adult population. The immaturity of the coagulation system, the hemodilution of these factors, platelets that are hyperreactive, and in some patients, the physiological changes associated with cyanosis makes it difficult to establish an adequate balance between thrombosis and excessive bleeding due to the characteristics of the hemostatic system. These factors should be considered to characterize ideal heparinization in the pediatric patients. Tools for the diagnosis of the heparin resistance, such as the sensitivity index, are useful for the management of these patients. So her research questions is, For better anticoagulation results, is it correct to increase the heparin dose from 300 units per kilo to 350 units per kilo for systemic anticoagulation in the pediatric population with congenital heart disease? For her methods, she's doing an experimental prospective cohort study where anticoagulation strategies will be evaluated. She has developed two groups. Group A, patients with heparin with 300 units per kilo, and the other group B with 350 units per kilo. She's going to be studying type of pathology, surgical procedure, some CPB time, cross-count time, systemic heparin dose, differences in the number of times that the heparin must be repeated during the pump run, basal ACT, and post-heparinization ACT. Also, type of circuit priming volume, how much blood the patient required during the surgical procedure, hemoglobin, and lowest temperature in CPB. So her results so far are: patients heparinized in group A, 300 units per kilo, require redose of heparin 2 times more than group B, which is group A, who has to be redosed more often than the patients that are heparinized with 350 units per kilo. Infants and scholar patients are the ones that require the most repetition of heparin. The group B, which is 350 units per kilo, shows ACT values close to 400 seconds, different from group A, that it's more difficult to get to 400 seconds of ACT. As number 4, she has the patients who require more transfusions are the newborn population and the younger infants in both group A and group B. But those in group B, 350 units per kilo, require more transfusions than those in group A, 60 versus 330 cc's per kilo. In newborns, 30 versus 22 cc's per kilo, and as younger infants. Regarding the level of sensitization of heparin as a prognostic value of resistance to heparin, only the pre-adolescent and adolescent population show no resistance to heparin with a sensitivity index higher than 1.3. This is a very nice concept that she's studying because it's really easy to get the formula. You subtract ACT post heparinization systemically, and then you subtract it with baseline ACT, and you get a value, and you divide it by the dose of heparin that you gave to the patient, and the index, if the number is higher than 1.3, the patient is most likely to develop heparin resistance. So her conclusions so far are: younger patients require greater systemic heparinization, probably due to the immaturity of their hemostatic system, although intraoperatively, they require more transfusions when being heparinized with higher dose. Female pediatric patients require more heparin than male patients. Newborn patients, even older patients, presented a higher heparin sensitivity index than larger patients, suggesting that the small population presents resistance to heparin. Up to now, everything indicates that the systemic heparinization dose of 350 units per kilo seems to be optimal for this population. So Alexei Suarez, he's from Quito, Ecuador, and he's studying behavior of Capiox FX25 advanced oxygenators during use at sea level versus altitude. Membrane oxygenators have gone through a complex evolution process that has improved their biocompatibility, efficiency, and safety. Understanding the performance of this vital tool in the cardiopulmonary bypass, it's required. The manufacturers test a performance of each oxygenator in vitro in the laboratory. However, the trials are conducted in a very controlled environment with conditions that sometimes do not resemble the actual clinical conditions that we all face every day. The PO2 in the gas compartment of the membrane will be determined in the first place by the barometric pressure. At sea level, the barometric pressure is 760 millimeters of mercury, and it decreases as you go up in altitude. At an altitude of 2,830, where he is, sometimes where he performs surgeries, pressure drops to 537 millimeters of mercury. Of this value, 47 belongs to water vapor, which leaves 490 millimeters of mercury for the rest of the gases. If we take in account that only 25% of oxygen remains from this value, then a PO2 of 103 would remain. This study was designed to find out how altitude impacts the oxygenator capacities of the Capiox FX25 Advance. So for his research question, he has, does the use of the Capiox 25 Advance at high altitudes affect the performance of this membrane oxygenator compared to when used at sea level? As methods, he's doing an observational, analytical, longitudinal, prospective, and multi-centric study where he's gonna measure and designing a population of patients in Ecuador at sea level, 30 meters, and a center where he performs cardiopulmonary bypass at 2,830 meters. Perfusion management was performed by the same perfusionists at both centers. A total of 3 simultaneous blood samples were taken for ABG and venous blood gases from the inlet and the outlet of the oxygenator. So he did it every 20 minutes, and he analyzed the VO2, which is the Fick formula to calculate the O2 transfer. And also he calculated the differential anoxic fraction, that is the percentage of FiO2 that does not contribute to oxygenating the blood. So for his preliminary results, he has oxygen transfer in Capiox FX25 advanced oxygenators does not vary with height. In the second objective that he's studying, the differential anoxic fraction is greater at altitude than at sea level. So his preliminary conclusions are, regardless of the height, the Terumo Capiox FX25 advanced membrane is capable of transferring oxygen in the same way at both heights, sea level and altitude. It is our theory that the altitude will decrease the maximum value of PO2 that can be obtained with a given FiO2, with which the anoxic differential fraction will increase. So calculating the percentage increase of this anoxic differential fraction in both populations, sea level and height, can help to understand how altitude impacts PO2 and therefore the oxygenation capacity of this gas exchange membrane. This is a nice new concept that he's adding to the master's program, which we are all studying.
My name is Gamaliel Rodriguez Acosta from Puerto Rico. The topic of my research is relationship between DO2 and acute renal failure in patients undergoing adult cardiac surgery with cardiopulmonary bypass. May 2022, April 2023, Mayagüez Medical Center, Mayagüez, Puerto Rico.
Okay, so Gamaliel is doing this excellent study at Puerto Rico. So for his introduction, he has that acute renal failure is one of the most worrying morbidities and mortality complications in cardiac surgery. It is known that acute renal failure occurs, among others, due to decreased DO2 supply. Recent investigations have considered that DO2 values maintained in CPB below 280 cc's per minute per square meter is an independent factor of acute renal failure. Although acute renal failure may be due to other factors that may or not be associated with decreased DO2, hemoglobin and pump flow play a fundamental role in oxygen delivery. medical centers that use a protocol to transfuse with very high hemoglobin values or specifically low hemoglobin values could be affected in the supply of oxygens to the kidney. So his research question regarding of centers, I'm correcting myself, of centers that have protocols that to transfuse with very low hemoglobin values. He's asking this research question. DO2 values less than 280 are related to the appearance of acute renal failure in patients undergoing cardiac surgery. So for his methods, analytical retrospective observational study by reviewing clinical perfusion records and clinical ICU records of patients who underwent cardiac surgery with CPB. He performed two groups. Group 1, patients with DO2 less than 280 during the cardiopulmonary bypass run, and group 2, DO2 above 280. The pre, trans, and post-surgical results of hemoglobin, hematocrit, urea, CPB flow, bond, creatinine, glomerular filtration, urine output, ABGs, and DO2 were measured 30 minutes, 1 hour at the start of the CPB, and then 24 and 48 hours post-op. So far, his results are showing this. The average hemoglobin managed in group 1, DO2 less than 280, was 6.8 grams per deciliters, and in group 2, DO2 above 280 was 8.8 grams per deciliters. Those patients with DO2 less than 280 in group 1 presented elevation of creatinine 1.22 times more than group 2 managed with a higher DO2. So for his conclusions, he is so far has this glomerular filtration and urine output volume in cc's per kilo per hour are being evaluated to determine, according to the rifle criteria, if the patients managed with DO2 less than 280 meet the criteria for acute renal failure for this population study.
Hola, mi nombre es Jorge Ramírez, soy de Chile y soy estudiante de la maestría de Perfusión y Circulación Extracorpórea de la Asociación Latinoamericana de Perfusión. Y mi tema de investigación es el impacto de la ultrafiltración modificada arteriovenosa en el hematocrito y lactatemia en pacientes pediátricos sometidos a circulación extracorpórea, según el tiempo de duración y tipo de cirugía cardíaca en el periodo de enero 2022 mayo 2023 en el Centro Cardiovascular CEIMAT, Santo Domingo, República Dominicana.
Okay, so Jorge is our last presentation. So he's studying the impact of MUF on hematocrit and lactate in pediatric patients undergoing CPB, and according to type of cardiac surgery, congenital cardiac surgery, in the period January 2022, May 2023, at CEIMAT Center, Dominican Republic, where the master's program is held. So for his introduction, he has that MUF is a medical technique used to treat fluid overload in pediatric critical patients, especially in cases of renal failure, obtaining as a benefit the reduction of total blood water accumulation observed after CPB, the improvement in left ventricular function, increase in hematocrit with concomitant reduction in the need for transfusion, improvement in hemostatic and dynamic lung compliance, and modification of complement activation. His research question was, is there a significant impact on hematocrit, lactate, and ultrafiltrate volume when using the MUF technique in each age group of the pediatric population according to the type of congenital heart surgery performed? Methods: a retrospective descriptive study of patients who underwent pediatric cardiac surgery with CPB from the period I mentioned before. Perfusion data was obtained from pediatric patients who underwent surgery. MUF patients, MUF was performed after CPB. The MUF time was determined previously with the surgeon and the anesthetist, according to the hemodynamic conditions of the patients. The patients were categorized by 6 age groups: newborns, younger infants, older infants, scholars, pre-adolescents, and adolescents. Data was compared with a non-MUF group, which was a patient who was done cough during the CPB run, but no MUF at the end. So far, his results are hematocrit increase on average 1.5% in newborns and in all populations. It increased most likely in the younger infants and in the older infants group. Lactate increased MUF on average from the start of the surgery to the weaning of the CPB by 1.2 in newborn, 0.6 in younger infants, 0.5 in older infants, 0.7 in scholars, 0.9 in pre-adolescents, and 1.2 in adolescents. On the other hand, lactate increased as well in cough patients more in all of the populations, but it didn't increase in the adolescents group more than in the MUF patients. It has to be said that in all patients, either cough and MUF, the lactate was increased due to the cardiopulmonary bypass properties of the systemic inflammatory response. The average volume of MUF performed by each group age was 20 cc per kilos in newborns, 20 cc per kilos in younger infants, 11 in older infants, 7.8 in scholars, 8 in pre-adolescents, and 4.7 in adolescents. So far, his conclusions are this: the use of MUF in surgeries with CPB is related to increase in hematocrit and variations in the volume of the modified ultrafiltration according to age. The hematocrit level increase as individual grows, being higher in older infants and lower in adolescents. This implies an increase in the concentration of red blood cells and blood viscosity. Lactate levels increase during surgery and weaning from extracorporeal circulation in all groups, with the greatest increase in pre-adolescents and adolescents. This suggests an increase in anaerobic metabolism and lactate production due to surgical stress. The MUF ultrafiltrate volume varies according to age, being higher in newborns and younger in infants, and lower in adolescents. This may indicate differences in the filtration capacity of hemoconcentrators, products, and or brands, and fluid hemostasis in different age group. MUF add values to cough. So this is his conclusion. So thank you very much from Latin American Perfusion Society and the Perfusion School.